So Dr. Surya Vijayan is here to discuss pathological aspects. I once again thank Dr. Jose for giving this opportunity and also congratulate Dr. Jose and Krishna Mohan team for the wonderful academic activities for PG students. Meantime, as the National Coordinator of IAP PG quiz, I invite all PG students to Gandhinagar on 23rd, Thursday, 1:30 p.m. a grand finale of IAP PG quiz. This few words will start our case discussion. First, I invite Dr. Mahoda Basim. He is a child present with acute weakness of both lower limb. How to approach and what is reason? So, both lower limb weakness, acute, as we know, it may be Guillain-Barré syndrome, traumatic, or it may be transverse mix. But Basit have another story to that. So over to Basit. Please start your screen sharing. Basit.
Okay, sir. Respected teachers and my dear friends, I'm here presenting a case of paraplegia, acute weakness of bilateral lower limb. So a 4-year-old boy coming from Ponnani, Malappuram, presented with irritability for 2 weeks, with fever for 7 days, cough for 5 days, inability to walk for 4 days, and breathlessness for 1 day. 4-year-old male child, developmentally normal, fully immunized child, present with irritability for 2 weeks, and had complaints of low-grade fever for 7 days duration. No diurnal variation of fever. It relieves his medication. Child developed cough for 5 days back and consulted a nearby physician. Given oral medication, it was non-productive cough. No diurnal variation or no postural variation. Since last 4 days, child was having bilateral lower limb weakness, and which was gradually in onset, progressed every day, and child was having difficulty in walking, and he also complains of difficulty in turning to one side on lying position. No history of any tingling sensation or numbness. No, there was no history of difficulty in lifting arm above head, no history of difficulty in mixing food or writing, buttoning or dressing or undressing, no history of difficulty in lifting head from the bed, no history of any diurnal variation of the weakness. Child also developed involuntary passage of urine within 1 week of admission. No history of any convulsions or altered sensorium, no history of headache or vomiting or blurring of vision, no history of any behavioral changes, no history of loss of memory or speech or language functions, no history of no history suggestive cranial involvement. There was no history of any recent vaccination or trauma, no history of pain in the back, no history of ear discharge, sore throat, fever, chills, and rest. Child also developed breathlessness for past 1 day. It was gradually in onset. There was no relieving factors or aggravating factors. It was deteriorating over time. There is no history of painful movements of neck, no history of any palpitation, cyanosis, no history of cough or chronic duration, no history of foul smelling sputum, no history of diarrhea or blood in stools, no history of bleeding manifestations or bleeding gums or bony tenderness. Coming to past history, there was no significant past history. There was no similar illness in the past. Antenatal history was uneventful. Child was born full term, LSCS, with 2.4 kg of birth weight. Child died soon after birth. Discharged on postnatal day 5. All the developmental milestones attained up to age. Child was immunized up to age. There was no significant family history. There was no similar illness in the family. On examination, child was conscious.
Basit, what is your impression at this point of time? Because child with lower limb weakness, onset, and without any upper story, means cortical, cranial, everything is normal. So it is predominantly a lower limb weakness, except some form of cough. There is no other findings. Is it okay?
Yes, sir. It was a acute onset of lower limb weakness.
Yeah.
No.
Go ahead. Examination.
Sir. On examination, child was conscious oriented, sick looking, undernourished child lying on bed with bilateral lower limbs extended rotated. Coming to vitals, pulse rate of 92 per minute, regular rhythm, volume, and character. No radial or radiofemoral delay. But child was tachypneic with a respiratory rate of 56 per minute, but respiration was regular. Abdominothoracic, BP was 96 mmHg of right arm, right lying position. Child was afebrile at the time of examination. Head to foot examination, head normal size and shape, no facial dysmorphism. There was no process in eyes, no other neck swellings or neck tenderness. Chest movements decreased on right side, but abdomen no dilated veins or scars. But bilateral lower limbs was externally rotated. No pallor, no spinal tenderness. Genitalia was normal. Sir, coming to nervous system examination, higher mental function of the child was normal. All the cranial nerves were within normal limit. Coming to motor system, there was no, on inspection, bulk of muscles, there was no wasting, atrophy or hypertrophy. Tone was bilateral lower limb was having hypotonia. Power, but the upper limb were having grade 5 on both bilaterally. Lower limbs, grade 2, symmetrical weakness of the lower limbs, bilateral grade 2. All the reflexes, superficial reflex, corneal, except corneal and conjunctival reflex or other superficial reflex were absent. Plantar was bilateral extensor plantar, and dependent reflex were 2 plus over the biceps, supinator, and triceps, but knee jerk and ankle jerk it was 1 plus. Sensory system examination, all the sensory function was decreased below the level of T6 vertebrae. But the cerebellar signs were negative, no signs of meningeal irritation. Skull and spine was exactly normal, no peripheral nerve thickening or ulcers. But after this, our possibilities were acute transverse myelitis or Guillain-Barré syndrome.
So, Basit, your respiratory complaint is a progression of the weakness. It's a Guillain-Barré syndrome. Ascending parallel. So,
Yes, sir.
respiratory problem may be, is it a part of Guillain-Barré syndrome or something else?
Sir, it can be part of Guillain-Barré syndrome due to diaphragmatic paralysis. So, it can be due to any other cause like any associated LRT.
Okay. Okay.
With the possibilities of acute transverse myelitis and Guillain-Barré syndrome, we started on the child was deteriorating over time, and we started on IVIG. But later the respiratory system examination showed decreased air entry over the right side and dullness on percussion. And chest X-ray was taken; it showed uniform opacity over the right side. UC thorax also showed some pleural effusion over the right side, and aspiration was done. ICD was inserted. In view of persistent weakness and respiratory distress, and the repeat X-ray was showing persisting opacity, we took an MRI. This was the chest X-ray showing pleural effusion, and this is the X-ray after ICD insertion. But blood routine examination was almost normal. This is a pleural fluid evaluation. It was showing X-ray effusion with protein of 3 gram. But there was no organism on gram stain, and culture was sterile, and there was no atypical cells seen. We also done lumbar puncture. It was almost it was showing more protein, almost 325 units of protein, but cells was less than 10. It was only 4 lymphocytes, and the nerve conduction study was normal. This was the MRI taken. It was showing extradural, extramedullary lesion extending from the D1 segment to D6 segment, and it was extending into the right paraspinal and extrapleural area through the D3, D4, and D4, D5 neural foramens. So the child was taken to neurosurgery, and they done laminectomy. This was the intraoperative photo, and this was the histopathology picture. Sir,
You can read. Basit, you can proceed.
it was showing uniform small round cells. The tumor cells almost size of two lymphocytes with round nuclei, fine stipulated chromatin, inconspicuous nucleoli scanned clear to eosinophilic cytoplasm, indistinct cytoplasmic membrane, sheet-like growth pattern, islands separated by dense fibrous tissues. Also, immunohistochemistry was CD99 was positive, and the histopathology report came as a malignant small blue round cell tumor and morphology consistent with extraskeletal living sarcoma. And the child was referred to RCC. From there, FISH was done. It was showing chromosomal rearrangement involving the living sarcoma 1 gene on chromosome 22q12. And from there, they started chemotherapy, and child gradually improved. Now he is able to sit and but he was not able to walk. He's not able to walk, but some sort of improvement in the power of lower limbs.
So, Basit, you again go back to your histopathology slide.
Okay, sir.
And now it is a non-osseous extraskeleton even sarcoma, very rare tumor, very rare type of presentation. So present like ascending type of weakness with respiratory system involvement. So it was unique. And I request Surega about the pathological. Surega.
Thank you, Dr. Ananthakrishnan, sir. Hope I am audible. Yes.
Yes, ma'am.
Sir, Kelkavallo. Yeah.
Yes, ma'am.
Okay.
Yeah, welcome.
First of all, I thank IAP for inviting the pathology department to this academic feast, and I am really blessed and thankful to represent our pathology department here. So my duty was assigned here to describe the pathological aspects of this case. So we had a 4-year-old child presenting with paraplegia, and pleural aspirate was done, which did not show any atypical cells. And the child was referred to the neurosurgery, and they have done the D1 to D4 laminectomy, tumor debulking surgery was done, and the specimen was sent to our department. And we received only a small, multiple small bits of tissue only. And after processing, this was the histopathological picture. This picture clearly shows uniform small round cell. To be more precise, it's small blue round cells, which are arranged in sheets. Dr. Basit, can you just, okay. This picture shows the cells are arranged in sheets. And if you want to describe the individual cells, they are small cells which are having scanty cytoplasm, and the nucleus are finely stippled. Nucleus is having finely stippled chromatin, and there was brisk mitosis, which means that it is a highly proliferating or aggressive tumor. And the second picture, you can see the cells arranged around a neuropil-like formation. That is, we call it as Homer right pseudo rosette formation was there. So with this picture, we had 1 or 3 differential diagnoses. The peroperative one diagnosis was lymphoma for them because it was a highly suckable tumor. So the lymphoma was considered as a differential diagnosis. But from the historical picture, the lymphoma was considered at the least diagnosis. The first thing was 2 diagnoses we considered were Ewing sarcoma and neuroblastoma. So to differentiate between these 2 DDs, we went for the IHC markers. Can you please show the next slide? Okay, this is the IHC markers. Actually, we did CD99, Ki67, and synaptophysin and chromogranin was also done to rule out neuroblastoma. And the final diagnosis came as CD99 came out to be strong membranous positivity, and Ki67 was 70 to 80% in the hotspot areas. So with this morphological and histopathological picture, we came to the diagnosis of extraskeletal Ewing sarcoma. As per WHO, the essential criteria for the diagnosis of this tumor is small blue round cells and IHC CD99 positivity. So with this, we gave the diagnosis as extraskeletal Ewing sarcoma, and final confirmation is always the genetic study, which in this case, I think they have done the genetic study and our diagnosis was finally confirmed, which shows the translocation. The most common translocation described in Ewing sarcoma is the translocation 1122, and so it was confirmed from RCC as extraskeletal Ewing sarcoma. Thank you, sir.
Surega, now
yes, sir.
I request Basil to say two slides about extra versus Ewing sarcoma. Only 2 slides, sir.
Sir, okay, sir. Extraskeletal Ewing sarcoma it is a rare tumor, belongs to Ewing sarcoma family of tumor, a group of small round cell tumors sharing common neural histology and genetic mechanism. It includes Ewing sarcoma, extraskeletal Ewing sarcoma, primitive neuroectodermal tumor, also known as Askin tumor of chest wall.
Okay. So as such, Ewing sarcoma is second commonest tumor of bone in pediatric age group, and I think extraskeleton is very rare. Before inviting audience, we have our first batch student, Dr. Badira. She is an oncologist, and she had a lot of paper in Ewing sarcoma. Dr. Badira, you are here, Dr. Badira?
Yeah. Hi. Thank you, sir. Yes,
Yeah.
I'm here.
Yeah. Can you say something about your experience?
Yeah. So what I want to highlight, I think, there are brilliant academicians right there in the group. But what I wanted to say about this case is, what should have ring the bell in you is, it's not like a typical schema. Typical chronology of a Guillain-Barré or a transverse myelitis, because the lower limb weakness, and without involvement of the upper limb weakness, there is respiratory distress. And so the diaphragm is unlikely to involve, without involvement of the upper limb. And in transverse, there is no bowel and bladder involvement. So there has to be something else which is causing the respiratory distress. Rightly, you pointed out sometimes it could have been a pneumonia also. And the other thing, rightly, so there has to be an index of suspicion, because malignancy is something which is diagnosed many a times when you have a high index of suspicion. And rightly, in this case, because of that persistent chest X-ray showing a nodular opacity, you went in the right direction of taking an MRI, which actually clinched the diagnosis. So Ewing sarcoma, or the chest wall Ewings, Ewings as such is a relatively rare tumor, and chest wall Ewings is also a rare tumor. So because of referral bias, we see every now and then Ewing sarcoma of the chest wall. So this is a posterior mediastinal mass, as you have said, a posterior mediastinal mass with an intraspinal extension. So which has features of a malignancy on an imaging, which is usually a solid or a solid cystic heterogeneous contrast enhancing lesion, a space occupying lesion with an intraspinal extension. As the pathologist Dr. Surega also pointed out, the 2 DDs are mainly neuroblastoma and Ewing sarcoma. And neuroblastoma typically on the imaging will have, on a CT if you have taken, will have had calcification. And the other one is Ewing sarcoma. Now, Ewing sarcoma also on imaging shows some diagnosis, because most of the Ewing sarcomas are usually bony involvement. So you can have the rib or the vertebra, in this case mostly rib destruction. So if it had been an Ewings of the bone, there would be rib destruction. If it's not an Ewings of the bone, which is like an extraosseous Ewings, there will not be rib involvement. So these actually, there are subtle clues on the imaging, actually CT scan, better to say, which will give you clues regarding the etiology. Now, extraskeletal and skeletal is, extraosseous and bony Ewings is something which is mainly radiologically differentiated. So as a pathology, it's one of the DDs of the small round blue cell tumors. And what I wanted to, it's a very chemosensitive as well as radiosensitive tumors. So if there is an intraspinal extension and acute paraparesis, your first treatment is actually supportive care. You start high dose steroids, and as I've said, if you have a suspicion of malignancy, you go in for a biopsy, and you can give chemotherapy. That is one of the options. And because they are extremely chemosensitive, usually you can see symptomatic improvement within 48 hours. Sometimes you cannot.
How is the prognosis? What is prognosis?
So the prognosis, again, there are two prognosis with this case. One is the prognosis with respect to the disease, and the other one is the neurological prognosis. Now, to know the prognosis with respect to the disease, you have to see whether the disease has metastasized to other organs. So that you have to do staging, other imaging, and whether it has involving other bones or bone marrow, you have to see. If it is not metastatic, the prognosis is very good as far as the disease is concerned. Now, neurological recovery, again, it depends upon the duration of paraparesis. Anything less than 4 weeks duration of paraparesis with immediate treatment and with appropriate treatment, there is a high chance of neurological recovery. In cases where it is more than 4 weeks, your chances of neurological recovery drastically drops down. But even then, I have to say in children, because the plasticity of the spinal cord, your neurological recovery is very good, except in cases where it is grade 0 power. So always try to treat them. But if it is more than a month, 4 weeks old paraparesis, the prognosis with respect to neurological recovery is usually guarded.
Okay, Badra is working as a oncologist at Tata Memory Hospital in Mumbai. Please stay with us. We have more malignancy cases to come. And I request Dr. Putron sir to give some comments.
Thank you. Thank you. First of all, congratulations, pathology team, to diagnose the patient without the final diagnosis of genetic markers, and happy to hear from Badra after a long gap. About this case, in the beginning itself, when you get a case of respiratory complaints followed by neurological problem, we'll be considering one of the possibilities. Commonest is a mycoplasma pneumonia. Another one is tuberculosis, and malignancies underlying is the last at the beginning. The possibility of connective tissue disorders are lowest in the 4-year-old child. At that stage, when you see the X-ray suggestive of an effusion, always one thing, better to avoid steroids and check the ESR. The ESR high indicates it's either a tuberculosis or a malignancy. ESR normal in many of the other entities. After that, if you suspect the ESR is high and shorter duration, very short duration tuberculosis is very unlikely, you need to consider malignancy a little higher. There, you need to check LDH and uric acid also, because that is one very important thing. And once your decision to go ahead with the MRIs was right, and you got a mass there, that when I heard the history, the bowel and bladder disturbance, initially I considered GBS-like situation, then bowel and bladder situation, put that in the parenchymal lesion. The very unusual thing is, there was no neuropathic, pain, radiculating pain, because the transverse myelitis situation is the sensory loss and all. That was the one thing which I considered. But when I saw the MRI, that was a little bit unusual, because extradural, you expect the root pain. That was absent in this case, a bit unusual. Anyway, it is one of the lessons for me. I'm first time seeing an Ewing sarcoma presenting like this with the atypical presentation. Congratulations, Sake. That is an interesting.
Thank you, sir. Any other opinion from audience? Because it's a very interesting case in both way, presentation and also extra-osseous Ewing sarcoma. Anybody had any experience with such a case? Anybody? Any neurologist from here? Okay. Thank you, Basit, for the wonderful presentation. And now we go for second case by Dr. Shalaba. Again, we are seeing very common lymph node, cervical lymph node. So many times we'll pass it as a reactive lymph node, or it may be suspicious of tuberculosis. But once in a while, rarely, you may get some unusual presentation also. So now Dr. Shalaba will present with the support of the pathologist, Dr. Surya Gaviji. Shalaba.
Good evening, all.
Okay, get ready, Shalaba. Okay.
So, I am going to present two cases which presented as
open the slide.
Slide open trans.
relax and calm, quiet, and don't get tensed.
Sir, can't,
Basit, help her.
Sir, is it visible now?
no.
No, no.
Sir, is it visible now?
Yeah. Okay.
Okay, sir. Okay.
Yeah.
I am going to present two cases in which children present as neck swelling. So coming to the first case, this was a 6-year-old girl, 6-year-old child present coming from Ponnani, presented with the swelling on the left side of the neck, which lasted for last 5 months. She had a history of contact with TB in the past. She also had a history of on and off fever for last 3 months, and there was no associated cough, breathlessness, dysphagia, weight loss, or any history suggestive of hyper or hypothyroidism. This was the swelling. It was a firm to hard, non-tender swelling, about 1 into 2 centimeter size, which moves with deglutition, and where there was no movement on protrusion of the tongue. This swelling was deep to deep fascia, and all other systemic examination was within the normal limit. Then on investigation, the child was found to have HbF 12.5 with total counts of 12,500, with TFT was within normal limit and Mandor test was negative. Chest X-ray was done and that was within normal limit. As it was suspected to be lymph node swelling, we started on one course of antibiotics, and child was also started on AKT therapy. And then to know detect the for further evaluation, thyroid scan was done, and in the scan there were reduced uptake of all the thyroid gland, with more on the left side, suggestive of a cold nodule, and report came to be as a cold nodule in the left lobe of thyroid. This was the image showing the cold nodule in left lobe of thyroid. Then FNAC was done, which showed follicular cells which was arranged in a papillary pattern, and following suggestive of papillary carcinoma of thyroid, and following that total thyroidectomy was done for the child. This was a specimen of post-thyroidectomy. The near total thyroidectomy with 3 into 2 centimeter nodule infiltrating trachea and left lobe and isthmus was removed. Post-operative period was uneventful. That was the first case. Then coming to the second case. This case was of a 13-year-old girl who presented with a swelling in the anterior aspect of the neck for past 6 months. She had an uncomfortable feeling while swallowing, and there was no history of any dysphagia, breathlessness, hoarseness of voice, and history of radiation exposure or family history of any thyroid cancer. Then child had also associated pallor was present. There was bilateral cervical lymphadenopathy measuring 1.5 into 1.5 centimeters, and thyroid gland was diffusely enlarged with the hard nodule over the left lateral aspect. Other systemic examination was found to be within normal. TFT was done, thyroid function test was normal. Then thyroid peroxidase antibody for further evaluation was done, which was found to be elevated. Then on evaluation, USG neck showed an enlarged thyroid gland with diffuse microcalcification, which suggestive of malignancy, with hypoechoic nodule and microcalcification in the left lobe, and involving the level 1B, 2, 3, and 4 lymph nodes. So for further evaluation, for further extension of the mass, we have done a CT thorax, which showed enhanced left lobe of thyroid with the enhancing nodule measuring 1.8 to 2.4, 3.2 centimeters, and enlarged mediastinal lymph nodes. FNAC was done, and it showed Bethesda category 6 malignant papillary carcinoma, suggestive of category 6 malignant papillary carcinoma thyroid. This was the FNAC smear. showing the follicular cells which was arranged in the papillary pattern. Then as we are suspected papillary carcinoma of thyroid, total thyroidectomy and central neck dissection with bilateral posterolateral neck dissection was done.
Stova, have you got any real specimen? Specimen of
Yes,
FNS
sir.
note after surgery you got specimen?
Yes, sir.
Okay, you can go back to slide. So here we got two children with a simple lymph node swelling. First child he had a history of contact with tuberculosis and also poor weight gain. And they had started from AKT from outside. So they had on AKT 4 months before coming to the hospital. Some questions like that, why AKT started from outside, and also the 2 months kind of had this one. So very common scenario lymph node, but both of them turned as thyroid malignancy, luckily papillary carcinoma. So Salva show you the histopathological side and over to Dr. Surega. Dr. Surega. Show the histopathology slide. Salva. Yeah.
Actually, this is the cytological smear. Thank you, Dr. Shalaba. I think the histopathological slide is not, I don't know. This is actually the cytology FNA smear. This is the case, second case.
You're a little bit
Here
loud,
the
madam.
cytologist-
Little bit loud.
This cytological smear of the second case, this one. And this shows a cellular smear showing the cells arranged in papillary pattern. And I think for the second case, we gave the diagnosis straight away. We gave the diagnosis as papillary carcinoma, TESDA category 6. That is the final diagnosis. And for the second case, both case total thyroidectomy was done. And actually for the first case, the histopathology, we could not retrieve the case. For the second case, it was given as that is 12-year-old child. The final diagnosis was given as papillary carcinoma thyroid, diffuse sclerosing variant of papillary carcinoma thyroid. And when we are comparing with the conventional carcinoma, papillary carcinoma, diffuse sclerosing variant is most commonly seen in pediatric population and also in young adults. Younger age group, we are seeing this variant. And when comparing to the conventional papillary carcinoma, this is a little bit more aggressive type of tumor. The behavior is more aggressive because it has got more chance for extrathyroidal extension as well as more chance for lymph node metastasis. In the first case, that 6-year-old child, the thyroidectomy specimen was shown, and it clearly described that the tumor was extending into the trachea and the nearby structures. And in the second case also, the tumor was almost reaching up to the resected margin, and many of the lymph nodes were showing positivity. Level 6, level 1, level 2, and level 3, many of the lymph nodes were showing positivity. So finally, we gave the diagnosis as papillary carcinoma, diffuse sclerosing variant, P3. P3 means that the tumor is confined to the thyroid, but there was lymph node metastasis. N1B was the final diagnosis. Thank you, sir.
Thank you, Dr. Surega. We have to give thyroid and supplementation also to suppress the thyroid action to TSH. So these patients should be treated with TSH. A meticulous follow-up is very important because they may get later lymph node metastasis. So periodical review is very important. Our second child is a tribal child, so very difficult to follow up. So I think many of us in this audience may see such a cases, not very rare. So to share your experience, Putson sir, or any other Putson sir?
Thank you, Shalaba, about the case presentation. When the younger child presented with an nodule in front, initially you consider all the possibilities. When the swallowing, it is moving up means it's related to the thyroid. When you see thyroid, the consistency is more important. You said it is a very firm to hard consistency and nodular. The possibility of a malignancy is high. Always the clinical examination, you need to follow whatever you have learned in surgery. Auscultate for the bruit, palpate the thyroid, and the functional examination. You need to look for the eye, you need to check the pulse, and the thyroid function clinical examination to be included. So don't jump to the investigation and bypass whatever disorder of the thyroid. Let it be malignancy also. You need to mention the thyroid function clinically. Then after the surgery, AK already pointed out the need for the supplementation lifelong thyroid. The other very, very important point in this case is what is the calcium level and phosphate level, because very likely with the total thyroidectomy, the parathyroid situation, calcium phosphorus is very, very important. Is there any evidence clinically of going into the spasm, hypocalcemia features? That is clinically, and lab investigation should be included. The second case, it's a 13-year-old girl child with a diffuse enlargement. Very, very likely that you are very likely to miss that for the Hashimoto's thyroiditis, especially when the investigation came as 1006 antimicrosomal antibody. So there is a message in that. Never leave that situation to a commenting. Always include this possibility of a malignancy, and there comes the help of the another lymph node in relation. So very likely this second case is missed. So that case didn't miss is a credit for you, your team. Thank you. Okay.
Any endocrinologist here? Pediatric endocrinologist, anybody related to endocrinologist here? Darling madam, do you have experience with the thyroid carcinoma? Darling madam, Dr. Jose. Dr. Jose or Dr. Darling madam, any senior? Okay. So we have a number, lots of cases pending. So we'll go for next case. It's another lymph node only. So now we are seeing a lymph node swelling tend to be suspected tuberculosis. Later proved, both of them are proved it is thyroid carcinoma. We are following both the patient. And now we have another lymph node. So I request another cervical lymph node. I request Dr. Amrita Narayan to present her case. Amrita Narayan. This is very interesting. So give a suggestion. We are expecting some interactive session also. So please give your idea also, valuable input. Unmute, unmute.
Sure. Is my screen visible, sir?
No, you open it. Basit.
Yes, sir. Sir, it is visible now?
Is it visible, sir?
Visible.
Good evening, everybody.
Not visible.
Screen is not visible.
You open it and go for turn. Oh yeah.
Yes.
Yes. Okay, sir. Good evening, sir. Good evening, everybody. We had a 2-year-old boy hailing from Palakkad. He came with the complaints of swelling behind the right ear for the past 1 year. So it was a 2-year-old boy, developmentally normal and immunized child with swelling behind the right ear since 1 year. And initially it was a very small swelling, and later it progressed over the last 6 months to a slightly larger size. There was no history of any pain or redness of swelling. There was no history of recurrent fever, cough, ear pain, throat pain, difficulty in swallowing, or ear infections. There was no history of swelling noted elsewhere. No history of weight loss, fatigue, tiredness, or bone pain. No history of any abdominal distension. No history of drug intake, travel history, or pets at home. there was nothing significant in the past history or the antenatal history. It was and natal and postnatal history as well was uneventful. There was nothing significant. And this was the third child of non-consanguineous marriage, and there was no history of any TB, malignancy, or recent infectious diseases in the other family members. And coming to the examination findings, the vitals were stable. Child was active and alert, and the vitals were stable. Child was afebrile.
Requesting others to unmute. Please unmute others. Please unmute. Others, please unmute.
Head to foot examination, everything was normal, other than the lymph node swelling behind the right ear. It measured about 2 into 2 centimeter. It was not fixed, not tender, mobile swelling, and the overlying skin was normal. There were no other palpable lymph nodes. Oral cavity, ear, everything else was normal in the examination. So this was the really small swelling that was just around 2 into 2 centimeter behind the right ear. And the examination was also normal. So it was just a single post-auricular lymphadenopathy. And at this point, the investigation showed that the HP was 10.6. Total counts was 11,000. Was not elevated. Out of this, polyps was 31%. 3%. Eosinophils 3%. Platelets was 2 lakh. CSR was also just around 12. We had done the peripheral smear initially, and that was showing microcytic hypochromic anemia. So this, since we didn't get any clues from this, we went and got an FNAC done. And as our FNAC, we got a microfilaria in the FNAC. And after that, we sent a repeat peripheral smear. So by Leishman staining, the repeat peripheral smear showed again microfilaria. This is in fact quite a rare presentation in the lymph node, and the peripheral smears of the parents were checked, and the smears were all normal. So, please.
Requesting others to unmute. Teaching section, academic section, disturb. You mute yourself.
So the treatment.
You can just go out also. Don't disturb others. Okay, continue.
Treatment is 6 mg per kg per day of DEC, which is given for a total of 12 days, or total dose of 72 mg per kg, or as a mass drug administration, it is given as orally once. DEC 6 mg per kg orally once, and albendazole 400 mg orally once. And in case there's you're suspecting onchocerciasis, single dose of ivermectin 150 microgram per kg orally once can be given. And this whole finding of microfilaria in the lymph node aspirate is a very rare presentation, and there have been a couple of case reports. This is one of a 13-year-old girl who presented with a cervical lymph node swelling, and then the FNAC from that showed microfilaria. And even though filariasis is quite prevalent in our areas, getting microfilaria from the lymph node is again slightly rare.
Go back to histopathology slide over to Surega. So, see, very, very rare. It is asymptomatic. It's totally. So there are so many case reports. 2 or 3 case reports are there. Asymptomatic or maybe with the symptomatic also, but not with classical failure. What we think elephantiasis. So it's a very accidental finding. So first we got from lymph node, then we got it from peripheral smear also. So we are very lucky because FNAC to get a microfilaria is very, very rare to get a microfilaria, and even we noted to suspect also. So congratulate pathology department. Over to Dr. Surega Vijay.
Yes, thank you, sir. Actually, this is a rare presentation. Why? Because when we examine the peripheral smear, usually in case of filariasis and all, we will be seeing eosinophilia accompanied. But in this case, there were no eosinophilia, so we were not at all suspecting microfilaria in the peripheral blood smear. And clinical suspicious was also not there. So in FNAC, as Sir told, we luckily got the filarial verb, and we could give a correct diagnosis of microfilaria. And in retro, after second peripheral smear was sent, and in that we could retrieve the microfilarial verb. And as Amrita told, lymph node presentation of filariasis is very rare. If at all, most commonly inguinal lymph node presentations we have seen, but cervical lymph node presentation as such is very, very rare. And moreover that this child was asymptomatic. The child was giving a history of 1 year duration. So, sir, I am also having a query. Can 1 year duration of lymph node without any other symptoms can present like this filaria? Have you seen such cases? 1 year duration.
Yeah, very localized swelling. There are reports like that. Totally asymptomatic without eosinophilia. So if it is a button to lymph node alone, it will not be active. And also one question is there. We engage with the health worker. There are 15 number of cases, 15 cases of filarias in that region. Tattamangalam, Palakkad, near Chittu. So
Okay,
we
sir.
engage them,
Okay, sir.
and there are some cases. But here it is we don't know whether most parents are native. So there are history or there are cases of failures in that region. So that is a very another important finding. So the treatment is another question. Child is sensibility. Anyway, we treat with the diabetes carbamazepine. Any other experience with anybody? Sir, any case you have seen?
No. Okay, first time I'm hearing. We had a dirophilaria presenting in the as subcutaneous nodules. Never this filaria within the lymph node. Very, very interesting indeed, because 1 year duration, no fever, and this is an unusual lymph node and no blood parasites. It's very rare. Anyway, you are documented in the histopathology. There is no need to doubt. Is it possible for different mechanisms of this worm? Because the way we see the larva migrans occurring in a different manner, just like that, is there a possibility of a mosquito biting directly on a lymph node? This particular lymph node is so superficial over the bone under the skin. So we need to postulate. It's just a postulation. Is it possible directly biting on it and injecting into the lymph node? It's not going outside like that. Just a thought. So seeing the rarest of the situation, I never encountered such a possibility.
Question, Dr. Janiki Madam. Janiki, any suggestion? Or Parvati Madam? Unmute, madam, unmute. And Janiki?
First of all, let me congratulate all the 4 cases were really good, excellent cases. And is it not necessary to take night blood for microfilaria?
We already got the microfilaria. There is no fever and rigor. So here it is a
No, in the usual routine peripheral smear, or did you get it in night blood?
We got in routine peripheral smear only. Routine smear only.
And regarding the thyroid cases, I would like to get the opinion of the pediatric surgeon. Dr. Shashikumar is there. No?
Sureka, your husband is there? Shashikumar? Madam, he is the wife of Dr. Shashikumar, a pediatric surgeon.
Shashikumar undallo avade.
No.
I think his name is there anyway.
Shashikumar? Because this case is a little complicated. So they have done surgery with the help of Mongo surgeon.
Yes,
Onco
sir.
surgeon.
They combined because extensive neck dissection they have to do.
Okay, sometimes you may get injury to the recurrent laryngeal nerve. That's also a risk.
Yeah.
And parathyroid injury removal also is quite common after thyroidectomy. Or Purushothaman has already mentioned.
Yeah. Janiki, any comments? Janiki?
Explanation for the lack of eosinophilia which you noted.
Say local, it may be localized disease. That may be one reason. Otherwise,
No, but
there is no
it's
fever.
not localized.
Yeah, peripheral smear
Not
also
localized.
you got the microfailure, so it's not localized. You can't say that it is localized.
It's not localized.
Okay.
Very unusual.
Yeah. So I think 2-3 case reports are there, very wonderful, from one case from India and also abroad also. we are going to publish it also.
And what has happened
And-
to the lymph node? Has it become
And
smaller?
it is on treatment only. We just patient yesterday only we discharged it. Today only we discharged it. So we are waiting for it. So we have 2 more cases. So from thoracic level to thyroid level, now we go a little upward. So now we have another indication by Dr. Needu. So Dr. Needu is presenting a case of precocious puberty, but some unusual features. I'm going to stop screen sharing and Needu start the presentation. So, any other comments during Needu? You can start your presentation. Meanwhile, any comments? Any other comments? Today, can you say it is which one? Which worm? This one? Wucheria or other one? Which one?
So from the smear, actually,
You can start. You can start in meanwhile.
Yeah. In our, we are most commonly seeing Wucheria only, sir. In Asian populations, we are seeing Brugia malai also. On the smear, I think it's finding it difficult to appreciate the morphology because of skinny characters. More in favor of Wucheria only. Microfilaria of Wucheria.
Okay, Needu, start. Basit, help her. Needu. So we have this. We have 2 more cases. This one and next one.
Is it visible now?
Screen visible?
No, not visible. I request all the audience, please mute. If we get disturbance, please mute yourself. Yourself, നമുക്ക് mute ചെയ്യാൻ പറ്റുമോ അവരെ?
Sir, is it visible now?
Yeah. Come proceed.
Good evening, everybody. I am presenting a rare antenatally detected CNS tumor. It was a 13-month-old girl from IAP Thrissur, and informant was mother. Presenting complaint was spotting per vaginum 1 month back, and she was admitted for the follow-up of intracranial space-occupying lesion. Antenatal history, she was the first child of non-consanguineous marriage. First trimester was uneventful. They received regular antenatal care. During second trimester, quickening felt at 6 months. Uneventful antenatal period. Anomaly scan was also normal. During third trimester, at 7th month, on routine evaluation, mother was detected to have high BP and start down tablet Nicardia. Antenatal USG done at 29 weeks showed a fetal brain hyperechoic round mass anterior to brainstem involving suprasellar area 3.2 into 3 centimeters size, suspecting craniopharyngioma or teratoma, displacing adjacent structures and circle of Willis. At 32 week 5 days, antenatal USG was repeated and it also showed well-defined fetal intracranial lower midline lesion with homogeneous echo texture. 3.6 into 3.3 into 3.7 centimeter, mild internal vascularity. Lesion was displacing circle of Willis. At 34 weeks, 4 days, again USG was repeated and also showed same findings. Then coming to the birth history, it was a vaginal delivery induced at 36 weeks, 3-day gestational age in view of severe preeclampsia. It was a female baby. Birth weight was 1.7 kg. Cried soon after birth. Clinically normal child. Neurological examination were within normal limits. Had respiratory distress soon after birth, which required oxygen by hood for 24 hours. Neurosurgery consultation was done and referred to higher center in view of antenatal detected intracranial lesion. She was discharged from our SNCU on postnatal day 11. Discharge weight was 1.635 kg. They came for follow-up in SNCU OPD once and then lost follow-up. Then coming to the present history, she now presented with blood-stained vaginal discharge at 1 year of age, lasted for 1 day. No history of trauma. The child is having good appetite and sharing family food diet. No increased frequency of urination noted. She's active and playful with good interaction with parents. There was no history of seizures, abnormal posturing, uprolling of eyes, weakness of limbs, any history suggestive of cranial nerve palsy. There was no history of recurrent vomiting or loss of consciousness. And developmentally, she was normal, and developmental age corresponds to 10 months. Vision and hearing also appears normal. Then she was fully immunized. Dietetic history, she's receiving adequate calories and proteins. According to parents, child is taking more feeds compared to other children of same age. Weight records available with them is plotted in the growth chart. It shows and her weight crossed 2 centiles. Coming to the family history, there was no family history of CNS tumors or other malignancies. So, socioeconomic status, father studied up to 9th standard. He's a vegetable seller, coming from a middle class family. Then coming to the examination, general appearance, child was active, alert and playful, appears obese, vitals were stable, head to foot examination showing head normal size, flat occiput with the plagiocephaly, anterior frontalia was closed, no sutural separation, no facial dysmorphism, eyes normal, no neurocutaneous markers or cephalioid spots. Spine was normal, no signs of hydrocephalus or raised ICT. Tanner staging showed B3, A1, P2, bilateral enlarged breast tissue, enlarged breast, no axillary hairs, stage 2 pubic hairs. And then anthropometry, weight and head length were in the 50 to 97th centile. Head circumference also in the 50 to 97th centile. Then system examination, neurological examination, higher functions appears normal. Child was active and alert. Cranial nerve, sensory system were normal. Sensory system, there is limitation for examination. Response to touch and pain present. Motor system, bulk bilaterally normal and bilaterally symmetrical and normal in both upper limbs and lower limbs. Power grade 4 plus all 4 limbs. Tone, hypotonia, mild hypotonia was there. Reflexes, dependent reflexes were normal. Bilateral extensor plantar response. No involuntary movements or truncal ataxia. Cardiovascular system, JVP was normal. Apex beat not palpable. S1, S2 heart sounds head normally. No murmurs. Respiratory system and abdominal examination also normal. Provisional diagnosis was intracranial tumor presenting as precocious puberty. Then coming to the investigations, blood routine examination were normal. Then hormonal studies showed normal thyroid function test and cortisol. FSH was slightly elevated. LH and estrogen markedly elevated. Serum prolactin was normal. Bone age was advanced, correspond to around 24 months. UST confirms the presence of bilateral homogeneous fibroglandular breast tissue. Then UST abdomen and pelvis showed adult type of uterus with a thickened endometrium and prominent uterine corpus and ovarian cyst suggestive of pubertal morphology. The MRI brain, which was taken in the immediate neonatal period, showed a well-defined extra-axial space-occupying lesion with lobulated margins in suprasellar and prepontine cisterns measuring 4.1 into 3.9 into 3.6 centimeter with minimal post-contrast enhancement and containing multiple serpiginous T2 hypointense components in the background of hyperintense stoma. The axial view showed the lesion overlays the clivus, no evidence of erosions of bone. It caused compression and posterior displacement of basilar artery, pons, membrane, and cerebellum. The pituitary infundibulum is not separately seen from the mass. No hydrocephalus was seen, no calcification seen. At that time, differential diagnosis were teratoma and craniopharyngioma. When they presented at 1 year, 1 month of age, MRI was again repeated. It showed a fairly well-defined extraaxial lesion in the suprasellar cistern with the mild interval increase in its size, suggestive of pedungulated large hypothalamic hamartoma presenting as precocious puberty. So our final diagnosis is true isosexual central precocious puberty secondary to an intracranial midline tumor, most likely to be hypothalamic.
I need 1 minute. So here we got a child with presenting with precocious puberty, antenatally detected mass, And after 1 month, we referred them to higher center for surgery because our center is not, they are referred to city Trivandrum. And the thing is that they lost follow-up at that time, COVID season, so they didn't turn up. So after 1 year, when there is a bleeding from vagina, they again came for follow-up. So here, interesting part is that such a large tumor means, initially to begin with 4 into 4, then it is a 5 into 5. It is not slowly growing, it is not rapidly growing, it will grow like the child. Means, according to child's age, it will grow. It is no other extraordinary growth like in mass. That's the feature of hamartoma. It is a locally spread, it only metastasis, it won't spread too much. So here, this child is with others asymptomatic, and but now she has some other feature. Again, Nindu, again, carry on.
Then she was treated with the leuprolide injection monthly, and she was referred for surgery. It was at Trivandrum, but imaging suggested inoperable location of tumor and hence advised medical management. Then after treatment, no further bleeding per vagina. SMR showed regression. Child developed gelastic seizures.
Sound is there? It is okay. Okay, next slide.
Then importance of this case, there is no existing case report available about hypothalamic hamartoma detected in antenatal period. And this much large hypothalamic hamartoma is quite unusual. So a few points about hypothalamic hamartoma. It's a developmental malformation with a disordered neuronal migration. It has 2 clinical phenotypes consisting of either development of central precocious puberty or the presence of gelastic features. It's the most common organic cause of central precocious puberty. Central precocious puberty is most likely to be not likely to be occur with large hypothalamic hamartoma lesions with attachment to tuber cinerum. It's also associated with the cognitive malfunctions and behavioral disorders. It can be either sessile, that is intrahypothalamic, or pedungulated, that is parahypothalamic. Sessile hypothalamic hamartoma may expand the hypothalamus. Pedungulated ones usually arise from the floor of the hypothalamus and extend inferiorly. It causes unregulated pulsatile release of gonadotropin releasing hormones, which causes very early onset and rapid progression of puberty. Treatment is medical management of seizures and precocious puberty and surgical management in refractory cases. Surgery is indicated if failed medical therapy in improving precocious puberty, neurological deficit caused by mass effect of hamartoma, or seizures, that is intractable epilepsy.
So, thank you. We published it also in the index journal. So, thank you, Dr. Needu, for the excellent presentation. So, here the thing is that any case of precocious puberty, gelastic, you ought to look for the hypothalamic hamartoma. What is that we know, because we are seeing so many cases of precocious puberty and gelastic due to this one. But here the thing is that antenatally detected tumor, and we are following up with this one, and also such a large mass without causing much neurological follow. So now invite opinion from the audience. Pushon sir,
Thank you, Andagasan. A very interesting case.
Stop the screen sharing and you ask the other side to start. You stop it. Sir.
Very interesting case. Because first time I'm seeing anyway this antenatal presentation. In this case, it was almost clear because everything happening with this sort of an antenatally detected hypothalamic area. This is puberty. They are related. When such a case is being followed up in the history and examination, we need to include a few more things. When you're getting a precocious puberty, don't be biased. That's the only problem, because there was a lesion diagnosed in the last trimester itself in the hypothalamo-pituitary area. So what can happen even if the child is losing follow-up? This case actually should not be losing follow-up. You should be getting the phone numbers and routinely they should be calling them. because you can't have an excuse for this patient. Then, and what happened over the follow-up is child developed normally, growth was normal, and the head circumference interesting was normal. Fontanelle closed normally. So what does that mean? It's not structurally producing any block, and the development, everything was proceeding normally. Main problem is the functional concept, functional disturbance. So we need to have included entire range of the hypothalamic disturbance in the history part. The appetite, the urine volume, insomnia, sleep disturbances, and the temperature. All these things can get deranged. Just because of precocious puberty, you only concentrate on that part only. So this should be included. All these things should be included in the history part. In the examination, very interesting, we all learned a pituitary lesion, bitemporal hemianopia, the field. Very, very difficult for a 2-year-old child. You can test the bitemporal hemianopia, but interestingly, you can mention whether the child is started walking, is bumping on the walls by sideways. It will be a midfield only. And whether he is looking at a ring which is moving side to the midline. So it won't be seeing something from the sides. But when only it comes to the midline, you'll be seeing. The visual field should be very, very interesting finding. Of course, the pupils, all these things. Anyway, they could have been a surgically amenable thing in the early period. It's unlucky. Anyway, it's a very slowly growing thing. Maybe we'll follow up. Very interesting case.
Thank you, sir.
AK muted on AK.
So some question like how you treat it. So as such, elastic seizure is very difficult to treat. Sometimes you get crying also. So when it is a laughing like this, the patient will be happy and they don't think otherwise. So it may be late presentation. Another aspect is that the EEG may be normal because it's deep-seated tumor. So normal surface EEG won't pick up it. So it may be normal EEG also. And of course, it is difficult to treat also because many anticonvulsant may not be, but sometimes they have to put on multiple anticonvulsant. And surgical decision, nowadays a gamma knife surgery, radio ablation, such things are there. Case report of a series of case report, some of them are improved with this one. Here, we lost follow-up, I think that during our COVID summit in the summit, patient discharges. So that is why we lost follow-up. We couldn't trace them. They could come also because of the transport and multiple person, they could come also. Tight timing. As such, we look for the generally look for the field defect as Sir mentioned, but we can't make anything. So Dr. Cyril, our HOD Dr. Cyril and Dr. Jose is here. Any comments? Cyril, sir?
Hi. It's very interesting. Only thing, we are not familiar with such cases. That's the problem.
So I think now we are going to the last case. Very, very rare. There is only case report also very, very rare. We are suspecting such a things. It is very much interesting. And again, we publish that one also. So over to Nagarjun. A child with liver failure, rolling fever, recurrent liver failure during every episode of fever. That is what is it? Over to Nagarjun.
Good evening to all. Is my screen is visible, sir?
No. Can I call Basit? Basit? Yeah, they're coming.
Good evening to all. I am going to present a rare case of recurrent liver failure following the febrile illness. This is a 15-month-old boy from Thrissur. This is a first child of non-consanguineous marriage, presented with the complaints of fever of 1 day and vomiting 3 episodes and lethargy. History of present illness. Fever was high-grade fever, not associated with the chills and rigor. He also had 3 episodes of vomiting, which was non-bilious and non-projectile vomiting. Mother also complains of that he was sleepier than before. And there is no history of any bleeding manifestation or blood transfusion. No history of any intake of food from outside. No history of any intake of indigenous medications. Coming to the past history, at 11 months of age, at the part of the fever workup for 3 days, he was found to have elevated liver enzymes with more than 8,000 with associated with coagulopathy. All the hepatic liver failure workup was negative, and he was managed conservatively with supportive therapy, with which he improved over a period of 5 to 6 days. Antenatal was uneventful, full-time normal delivery, no history of any neonatal jaundice, blood transfusion, no history of any umbilical vein canalization. Developmentally was normal, family history, no significant family history. At the time of admission, coming to general physical examination, he was febrile. There is no facial dysmorphism. Child was alert but sleepy. Pulse rate of 120 per minute, good volume and regular rhythm. Respiratory rate of 24 minutes. BP was 80 and 60. GRBS was 106. Jaundice was present, but no pallor or any stigma of chronic liver disease. Coming to the systemic examination, per abdomen was soft and liver palpable 2 cm below the right castrum margin with a span of 7 cm. Soft and mild tenderness present, but spleen was not palpable. Other system was within normal limit. Immunization showing the hemoglobin at 12 and total count of 6,200, and ammonia was elevated and lactate was 25. Platelet was normal. So bilirubin was 2.5 and direct of 1.5, and with the increased OTPT of 8,500 and 8,600 at the time of admission, it was gradually decreasing over the days. Other system was like electrolytes and urine routine was normal. Sepsis screening was negative. Child was managed conservatively, and he made a complete recovery in both clinical and parameters with this supportive message.
I'm going to go back to the immunization part. So we are getting very high STOT, STPT, also later bilirubin also, and the PT, APT also prolonged. So all features of liver failure, isn't it?
Yes.
Okay. Next.
Because of suspecting a rare case, because 2 episodes of liver failure, we suspecting a rare case of acute liver failure. We convinced the parents, and clinical exam sequencing was sent. It showed that there is a novel homozygous mutation in the NBAS2 gene, which is associated with the acute liver failure syndrome type 2. Infantile liver failure syndrome 2 is a rare autosomal recessive genetic condition. It is manifested as an acute liver failure episode or occasionally with the elevation in liver enzymes, which is triggered by the febrile illnesses, and there is a complete recovery of liver function after that. It is in this condition there is a mutation in the neuroblastoma amplified sequence gene, and there is NBAS gene. It is located in the chromosome 2. NBAS protein is a component of SNARE complex and syntaxin 18 complex, which involved in the transport of Golgi to endoplasmic reticulum transport. It also interacts with the protein P31. This P31 protein's defect can induce the hepatocyte apoptosis by increasing the relative expression of stress response gene in the endoplasmic reticulum. Currently, there is no cure treatment is available currently. We have to avoid provocative infection by preventive strategies, and supportive measures are available.
So this instance syntax 18, so go back. So this syntax 18 and the P31 protein, we are very concerned with the Golgi to endoarticular transport, and they are very thermosensitive. That is important. So every time child developing fever, there will be chance for hepatic failure. That was severe hepatic failure. This patient admitted 3 times. And the only cure is there's no as a treatment. What we used to do is that we endured the gastroenteritis from Amrita also. The child was admitted in Amrita also. So we have to give control fever, okay, paracetamol always, and you have to prevent hypoglycemia. Whenever the child is getting fever, give too much glucose. You can prevent it, and elasticity also you can provide. Overall symptomicity and this one. And now patient is a 3-year-old on follow-up. We don't know. There is a younger sibling also there. Because totally asymptomatic. So it is a clinical extra-frequent diagnosis. I agree. But every time with the fever, you are getting high level of transmissibility level, and only very, very few case reports are there. Only it's not very studied, and very, very few number of cases are there, and that is why we are presenting. So think about such a rare things. about the, and as the child grows older, they become less and less symptomatic. But the thing is that we have to be very careful because every time child gets fever, the mother will be very tensed up. Every time with the fever, they will be very alarmed, and such things are there. So now I invite questions from audience. Purusha sir, you have seen such a case, sir? Purusha sir?
Thank you. Nagarjun, in this case, when you get a case like this one, very important.
Our case is over. You can go for discussion. Too much, no problem. Screen sharing stop for you. Another screen sharing stop for you.
Screen sharing. Okay.
Okay, sir.
We had experiences of drug-induced liver injury. We may be missing. Episodic also sometimes possible because they may be giving episodically. That's one point to be kept in the history. Is there a possibility of a drug given during the fever? So we may be considering the fever as a triggering factor of inborn metabolism. But the other thing is also possible. For the fever, they have given some drug which is responsible. That is to be kept. In the history, always include the pedigree chart meticulously in all these cases. Very, very important. In the examination, the liver size and consistency is very important because even though we are getting a genetic diagnosis, maybe we are misled by the genetics. Sometimes many genetic things will be coming and we may be attributing it to that. If your clinical features and the common things are not fitting, don't conclude that is the basic reason. In this case, because many other metabolic disorders presenting like this with a fever or infection triggering an acute liver injury is out of which the investigation which you missed is the blood sugar level and the ABG part. Nagarjun, specifically, you should have mentioned the ABG. Anion gap ABG or a non-anion gap acidosis because urea cycle abnormality and the organic acidemias is very, very important because many other metabolic problems, subtle variants are all possible here. So ABG is very important. And the blood sugar also, because when you said the hyperammonemia, it's not that significant. 200 is not that high actually. About 200 definitely included, but it's not. Here, lactic acid, organic ABG with an anion gap blood sugar because the fatty acid disorders, mitochondrial disorders, many of the organic acidemias are all very, very important commoner entities. Few of them can be treated with the megavitamins and other things also. So always consider those things before you attribute this genetic, because genetics sometimes in the coming decades, everybody will be bypassing the clinical and the common possibilities. And last word will be the genetics. Genetics sometimes can be misleading. Thank you. All the cases are wonderful, interesting.
Thank you for suggestion by Dr. Pushpa sir, because we are also supporting clinical examination. So we roll out almost all problem by clinical examination. But it's a short case. Last case, I think APG also done a present in a short time. So any other opinion about any cases? Because any other suggestion, comments, or any other questions from about any of these 5 cases? You can unmute and you can ask questions because many of them come across some of the experiences, so you can share the experience. Today, any experience with the hematoma, hypothalamic hematoma?
My experience, I haven't seen the specimens of any hypothalamic hematoma.
Yeah, usually they want to surgery.
Might have seen it or not.
So, thank you, Dr. Jose. Actually, Dr. Jose asked me to present a case presentation for PG students, but it is there everywhere. All India level, we can see so many case presentations. We thought we will share our experience with some rare cases. And also it is a stimulation for our PG students also. And the importance of keeping the records, importance of follow-up with the patient, involving some multi-specialty departments, like pediatric surgery, pathology, all are very important. So I would like to thank first Dr. Jose and Krishnamukhan and the IAP Kerala team and also my students, Dr. Salaba, Dr. Basit, Dr. Amrita, Dr. Needu, and Dr. Nagarjan. No, of course, our pathologist, Surya Vijay, and also our teacher, Dr. Purushottam sir, and also my HOD, Dr. Cyril and Dr. Janaki. So over to Jose. Thank you once again, Jose.
Thank you, Dr. Ananthakeshavan, for excellent case scenarios, because it's an experience for all of us. Regarding with a rare case we come across, we have the dilemma to narrate how to approach it. A difficult case. A very beautiful presentation, Dr. Ananthakeshavan and team of Thrissur Medical College. Again, supported by the pathologist Surekha Madam. He readily accepted our invitation and to come to our IAP platform to discuss the rare issues in how to approach and pathological aspect is regarding. Of course, Dr. Cyril is there, Dr. Janaki Madam is there, both of them supported the Ananthakeshavan for this case scenarios. I think this is very useful for all of us, not all PG students, all the practicing pediatricians also useful. And of course, our teacher of teacher, Purushottam sir, always with our IAP PG teaching program. So the Purushottam presence is always inspiring and boosts to our all activities. Thank you, Purushottam, for always with us regarding all and very beautiful comments on different issues. He commented every aspect. So Purushottam sir ready to answer any case discussion. He is have ready-made answer for every question. So thank you, Purushottam sir, and Janaki Madam and Thrissur team and Surekha and Ananthakeshavan for excellent presentation. And thank you on the behalf of IAP Kerala. I thank you all of you for this beautiful presentation. Almost 100 PG students have joined the program. I see this a very grand success today. This series. Thank you. Thank you, Ananthakeshavan.
Thank you very much and good night.
Thank you. Good night. Good night. Good night. Good night. Good night. Good night.
Thank you, Sureka.
Thank you, sir. Thank you. Thank you. Thank you,
Cyril
sir.
sir.
Good night.